Welcome everybody to this Perplexing Presentations and Fabricated and Induced Illness Masterclass on behalf of North Yorkshire and City of York Safeguarding Partnerships. I'm Jackie Hurrigan. I'm designated nurse for safeguarding for the Integrated Care Board, and my colleague who's supporting this presentation is Sarah. Sarah, do you want to introduce yourself?
Yeah, hello everybody. I'm Sarah Snowden. I'm a consultant paediatrician in York, and I'm designated doctor for safeguarding children and children in care, one of the two designated doctors. My colleague Natalie Lythe is also on this call for later on questions if we have any.
Okay, so if you've got a question, please use the normal rules of Teams meetings and pop your hand up. You can also put things in the chat if you wish, and I certainly don't mind if you interject as you're going along. In fact, I find training is so much better if we all have a discussion as we're going along. Just a reminder, with all safeguarding training, there can be sensitive and upsetting material in training, so if you find it difficult, please find yourself support or stay behind if you want to talk to us afterwards. Happy to support you, but please don't leave this session being upset by anything that you might hear. Not that I'm expecting that to happen, but I just want to say that. Okay, so I will move on if I can move my slides on. So this masterclass is here to be, well, we've just launched our local guidance.
Oh, Jackie, you've accidentally just gone on to mute.
I didn't mute myself, so somebody must have muted me. Oh, I wish people had stopped popping in because I just can't concentrate.
Really
yes,
good.
we've recently we have recently launched our local Fabricated Illness and Perplexing Presentations guidance. It's an update of previous guidance, and we wanted to make sure that it was accepted and acknowledged by a range of practitioners, hence why we've put this masterclass on. So please have a look at it after this session if you've not had a look at it as yet, and we'll share with you what it looks like, and Claire can probably put the links in the chat. So this session is around increasing understanding of fabricated and induced illness. We call it FII and PP in safeguarding, but I will try to avoid abbreviations. To consider the Royal College of Paediatrics and Child Health's guidance on the management of FII and PP, Perplexing Presentations, which was updated last in 2021. That is the guru of our guidance, and that's what our local guidance is developed alongside. To explore the roles and responsibilities of those individuals in cases where there is fabricated or induced illness and perplexing presentations suspected, including when a referral is required to go to children's social care. And there's a certain point where that happens, and we'll talk about that as we go through. And to consider the specific role of education and the development of health and education rehabilitation plans for perplexing presentation. Now, I'm just drawing your attention, that is not a health and education, or why do I always get them mixed up? EHCP. It is which is an education healthcare plan for children with special educational needs. This is a health and education rehabilitation plan, which is different for cases where there are perplexing presentations. So don't get them mixed up in abbreviations, because they are very different. Is everybody happy with that? Any questions so far? Okay, I'll move on to Sarah. Tell me when you want to move the slides on, Sarah.
Thank you, Jackie. Yeah, so this is, if you Google the latest guidance, this is the Royal College of Paediatrics and Child Health national guidance, and so that's very much what we're following here. So you can see it's entitled Perplexing Presentations and Fabricated or Induced Illness, FII, in Children. Royal College guidance. As Jackie has said, that was sorry, somebody's saying they can't hear. I believe it's okay our end, so I'm very sorry that you can't hear, but we'll just carry on because I think most people can hear.
I've changed my settings. Thank you.
Great. So this, as Jackie said, it was updated in February 2021, and basically, yeah, that's what we're following. And so next slide, please, Jackie. It was kind of
Yeah.
brought significant change.
Yeah, can I just come in there, Sarah, just to say one of the biggest change in that guidance in 2021 was the introduction of perplexing presentations. Before that, this was fabricated and induced illness. So that was the big change about actually where those presentations are really perplexing and we don't quite understand. And that's the first stage, which was what we're going to talk through. But that was the big change in that 2021 practice guidance.
Yeah, thank you. So these are our local guidances for City of York Safeguarding Children Partnership and for North Yorkshire Safeguarding Children Partnership. And so if you just, again, go to the partnership websites, and they're quite easy to find, I hope. And we have recently updated those to really make it a bit more robust and easy to follow according to that national guidance. We kind of have emphasised this education and rehabilitation health plan, and also we'll tell you later, but we're emphasising that in perplexing presentations we shouldn't sort of allow drift, and it's important to review progress every 3 months.
Yeah,
Thanks,
they're
Jackie.
one in the same. Those guidances are one in the same. They look different, but the actual contents is one in the same.
So what is a perplexing presentation? So this is the definition. Perplexing presentation, as we said, it was introduced in the 2021 guidance to describe the commonly encountered situation where there are alerting signs of possible FII, but we don't think it's yet amounting to likely or actual significant harm. So when it's when the full state of the child's health is not yet clear, but there's also no perceived risk of immediate serious harm to the child's physical health or life. So basically it's the cases where you might think, well, that's a bit odd, that doesn't make sense, and your feeling is that things aren't fitting together, and what you're seeing in a child isn't really making sense from what parents or carers are telling you. Thanks, Jackie.
Sorry, it's really difficult to find where I moved them on.
There we go. So we've got an example of a case study where there is a perplexing presentation and how it might present. So this is a secondary school age child who we know has a number of confirmed but also more reported health conditions that have resulted in time away from their education and missing a lot of school. We know from what their parent or carer has said that they're under the care of a consultant at the hospital. They're likely to be under the care of a paediatric consultant at the hospital. But also we become aware that they are having frequent attendances at unscheduled care settings. And what we mean by that is basically going to the emergency department, A&E, going to out of hours GP services, really presenting to, with health needs a high number of times. Mother has advised school that the child needs to be placed under significant restrictions on their activities. So it might be missing break time, having to stay in, could be all sorts of things, but restrictions being placed on what they're able to do at school so that it would stop them accessing the full curriculum. But school are not confident that this level of restriction is required, because what they observe when the child is at school and away from their parent or carer does not fit with what they're being told. Thanks, Jackie. So we just thought, did anybody have any comments either by putting your hand up or in the chat about if you had that presentation, what sort of next steps you might think were needed?
Does anybody have a familiar situation like that they've had that? I can see there's quite a few schools on the session. Anybody, any thoughts? So even if you're not in schools and that would be something that you came across, what are your thoughts?
Yeah, so that's interesting. Somebody's put gathering records together, absolutely, to create this thing we call a chronology. Sometimes they're really complicated to gather together because most of these cases will have presented to different people with different things being said quite frequently. So yeah, discussion with colleagues, that's really important, and potentially with mum, absolutely. That might be the first case. It's like try to get more information from the parent or carer.
Yeah, Talk to the
Talking to the
child.
child, number one. Yeah,
Excellent, excellent.
absolutely.
Somebody talked about a bit further at the beginning of the chat and spotted what medical evidence has the parent got to show to the school.
Yeah, so absolutely. So if mum is working with you, you could say, oh, is it at all possible for you to share, would you give permission to share any letter about your child's health condition? So that might be something to do. Speaking to the child and asking how they feel. Yeah, ask them how they feel in different environments. Yeah.
Melanie, did you
So
want to come in? Because I noticed you had your hand up, but you popped it down.
It was
Sorry.
some of that was the same about talking to the child as well, but also we do have these cases more often than not, to be honest. And what I'm
Yes.
thinking is, because they're quite low level at some point, you know, they start to escalate, and because there's so many services involved, it doesn't always flag up very quickly.
Yes,
and we have come across this before, but I work for a Sendias, which goes across health, social care, and education. And we do pick them up, but it's not, it's kind of shifting ground a little bit. So it's a little bit hard sometimes to actually pick up the correct, clear story of what's going on.
Yeah,
that's just my experience.
No, they can be very difficult cases to work through, and there can be a start of a concern that then can either go away with further discussions or escalate once you gather further discussions. But they can be, well, hence why we've got guidance, hence why we're doing these classes to acknowledge actually this is a multi-agency, can be a multi-agency concern that we need to work together. And it's a jigsaw piece, isn't it, of really understanding. But you're right, it can be really hard. It can be really hard, and we need support when these cases highlight, because they can be very difficult to manage. Just one question I've got for people as well, because it's really good. Oh, Jess has put host meeting with all professionals and families to provide single support. Absolutely.
that's what we're going to get to, Jess.
Yeah, absolutely. When wouldn't we talk to the family? Is there any point when we wouldn't talk to the family? If there's a risk to the child, absolutely. I think, Joanne?
Yes, it's putting my hand up to reply. Yeah, I think somebody said is if we think the child's at risk of harm. I mean, my job is that I'm one of the strategy nurses in North Yorkshire. So this is the sort of thing that might end up at strategy. But obviously, if they were under a paediatrician, we would hope to have that paediatrician at the meeting. Which doesn't always happen, but that'd be really useful. Because also, you know, sometimes I find as well, parents will say to school, well, they've got an autism diagnosis, and you know, but they can't provide any evidence, and so in strategy, then we're looking at the record to see if it's on there.
Absolutely.
You know, sometimes it isn't. It's just that the parents, that's what they think. You know.
Yeah, absolutely. And of course, there is also the diagnosis of autism as a diagnosis that are now completed by private providers. There's also that which we see in records quite often, where it's noted that the child has an autism assessment, and then that becomes a truth. Somebody said we've got an autism assessment, but they actually haven't, and it becomes the truth, and it follows the record that this is actually happens. There's no actual diagnosis that's ever been happened. Yeah. And Sarah, did you want to? Sorry, I've interjected really well there.
No, not at all. No, not at all. It's all really good. Yeah, I mean, people are also putting the difficulties with that. I think whichever agency you're working in, to remember to just keep things to the facts. And if the parents or carers are saying things to you, putting that down as a, you know, parent or carer, you know, mother says this, and putting it in quotations. And then if you've got actual facts, you know, observe facts, putting that down as well, and that can all be really helpful then when people get together and look at building this chronology of all the agencies. I can see the comments there. It's very difficult when say the child is or young person is having a mental health need or condition, and absolutely, because it may be something that's not yet been fully assessed. But again, I suppose it's just sticking to what you're observing and what you're being told, and gathering the information, and then knowing when to bring people together when you do just have snippets but you're concerned. Yeah, complicating factors of GPs charging for supporting letters. Well, that is really difficult, isn't it? I don't have any solution for that one. Self-reported, yeah, thanks Elaine. Self-reported, yeah, so and so reports, or the child self-reports this or whatever.
Yeah.
Right, so shall we just go to
So
the
there's
next
an
slide?
answer
Thank
there
you.
from Spa Surgery
yeah.
saying a summary printout from a GP should be free of charge, but a letter that takes time to write is chargeable. But a summary printout from a GP, so maybe that's what a parent should be asking for. Maybe that's more of a accessible
Maybe.
thing.
I mean, if you're needing that kind of information, it sort of feels as though we should be going on to the next step though here,
Yes.
I think, with the professionals meeting. So in the Royal College guidance, that advises that if the initial concerns arise directly from school as opposed to health, it's recommended that school explain to the parents that information is required from health to understand the concerns, i.e. if school has got concerned about poor school attendance or that the child isn't able to participate in things fully. And it's then appropriate for either the parents or education, if they've got consent from the parents, to contact health, and that might be whoever the parent is saying is involved. So it's either the GP or the consultant paediatrician or a child psychiatrist with the query about the actual health of the child. But if the parents don't agree to a health assessment and the sharing of information about the child, the schools then need to decide what action they should take following their national safeguarding guidance. And so at this stage, professionals should not use the term FII, fabricated and induced illness, terminology, as the state of the child's health has not been fully assessed. And if primary healthcare, so if the GP is the only contact for the child, they may wish to refer to a paediatrician for further assessment. And that's well, it's not a common referral, but it's a fairly common thing that paediatricians see, where GPs refer in going, there's this, and this, but it doesn't make sense. Please could you review the child and give us a summary of what your opinion is about their health. Next slide, please. Thanks,
We've got
Jackie.
a couple of comments in the chat saying we've had an issue and it's very difficult to get with the check with the hospital GP, and somebody else has put the similar as not contact back. Which agency is Sarah and Kirsten from? Sarah and Kirsten, which agencies are you from? School, Kirsten, school in Harrogate, or?
Yeah, I'm from Harrogate Grammar.
Okay. And do you have a safeguarding lead within your DSL within your schools that can escalate those?
That is me. I am the DSL.
Okay. And who supports you in the partnership in North Yorkshire? Sorry, I'm in York, so we have a lead for our DSLs. Do you have somebody in North Yorkshire? I'm not as clear.
I'm not too sure, to be honest. I think that's part of our question, is because I came to some training that you delivered in September about this issue. We then flagged, we got parental permission, we went to GPs, and a number of GPs would get no contact back, but I'm not really sure what we then next do. Who would we escalate to?
Okay. Hannah's come in from a North Yorkshire perspective. Hannah?
Hi, shall we pick this up outside of this? Would that be helpful?
So.
I'll put my email address in the chat.
You can. That's great. Thanks, Hannah. Thank you very much. Sorry, Sarah, did you come to your next slide?
Thank you. Yeah.
Okay.
So in summary, about if you were to get a case similar to this, where it's a perplexing presentation, what we're supposed to do is what we've just said. So it's with parental consent. School can contract whoever in health, either the GP or the paediatrician, to discuss their concerns. It's probably via a letter saying, can we have a conversation about this? The impact on the child's education and how they can offer support. And then the consultant paediatrician, at that point, it would be their responsibility to coordinate and gather together a professionals meeting. And that's inviting everyone that's important in the contact with that young person and family to gain a full picture of the strengths but also the concerns. And again, that's with parental consent. that we would inform, if we don't think there's a danger to the child, we would inform the parents or carers that we thought that a professionals meeting to get everyone together and talk about how we can help support them is the right way forward. So if that professionals meeting takes place, that sometimes can be quite hard to coordinate, but if that takes place and it concludes that there are no immediate concerns, but it's still unclear why the health issues are impacting as the carer reports them, that's at the point that the paediatrician would lead in exploring and monitoring, but basically writing up this thing called a Health and Education Rehabilitation Plan. And that's something that I think maybe in the past we haven't been so good at, but that's a real focus of what we'd like to try to do with these cases. Because then it's very clear as to who's responsible for doing what to support that child and family. But the other important bit is that in the past we may have set those up, but sometimes, you know, it's important not to have drift, because actually they're meant to be, you know, with some smart objectives on it, so that actually we can have a defined time where you can reassess and see, has there been progress or have there been more concerns following that sort of information gathering and sort of observation time, I suppose, where we've given people tasks on the education, health and education rehabilitation plan. So every 3 months at that point, you would meet to see, have the aims been fulfilled? And is the child getting better, and are they being restored to their optimal health and functioning? But if there are ongoing concerns or consent is not going to do any of this, that's when you need to consider the next steps. Thank you, Jackie.
Yeah, there's a question in the chat regarding what is the process for children who are homeschooled. I suppose that depends on where the concerns are coming from. So whoever has highlighted those concerns, because it doesn't always come from school, it can come from lots of different agencies. It may be that a GP has got a concern and concerning it's homeschooled. It may be that it's come from a nursery or something else. So it depends. It's the same process. We've just used a demonstration of a child that was in school here, because a lot of our children are in school, obviously. But if they're homeschooled, it depends where the concern has come from in the first place, and it would be that individual who's got that concern that would follow the process. Does that answer that question? Yes, perfect. Okay. Okay, Sarah.
So here's a summary of how the Health and Education Rehabilitation Plan works. So as I said, the plan is usually led by one agency, but most commonly that's the paediatric consultant, because if you've got concerns with a child who's got lots of reported health issues, really the GP needs to be referring into secondary care at that point. So it should involve education and children's social care if they're already involved, but if they're not already involved, there might not be a social worker at those meetings. The GP should be invited. They may not be able to attend, but certainly the fact that one is happening they should be informed about that, and they should be asked to provide some information. Ideally, they should be asked to come if they do have the time, but acknowledging that these cases are complex and probably causing a high workload for their practice as well. And as I've said, it must specify timescales and intended outcomes and have a review date of, well, it says at least 3 months, but it really is a review date of no more than 3 months. And there needs to be agreement when it's being drawn up about who in the professional network will hold responsibility really for coordinating and monitoring each item on the plan. If the parents disagree or lack of engagement becomes apparent as time goes on, then that is the point when a referral to social care is required, and the reasons explained to the parents, where you can use this as an example and say, well, this is the plan that we have come up with to support you, and it's you know, we're not achieving things and the child is getting no better or is getting worse. It's at that point that we would involve social care if they're not involved already.
And this process at this point is open and honest conversations and supportive of the parents and working alongside the parents in order to address the concerns regarding their child and supporting them with those concerns. So it's very open and honest and collaborative with the parents and the family. Oops, I got past 2 things. Okay. So moving over to me. Sarah, do you want to monitor the chat because I can't monitor the chat at the same time? Thank you. Yeah. Anything comes up. Perfect. So fabricated and induced illness. So that's where the FII comes from. I have to say it's rare. It's a rare form of child abuse. And it happens when a parent or carer exaggerates or deliberately causes symptoms or illness in their child. The parent or carer tries to convince healthcare professionals, or any professionals, but it does say in the guidance healthcare professionals, that the child is ill or that their condition is worse than it really is. And from experience of cases that I have worked with of fabricated or induced illness, in general, the children or the child has got some health needs. Not always, but in general they have. And it can be an exaggeration or extension of that. The parent or carer does not necessarily intend to deceive healthcare professionals, but their behaviour is likely to harm their child. For example, the child might have unnecessary treatment or tests, or made to believe that they're ill and have their education disrupted. So it's that exaggeration that's having that impact on the child's welfare that is of concern. FII used to be known as Munchausen's syndrome by proxy, but we don't use that term anymore, and it should not be confused with Munchausen syndrome, where the person pretends to be ill or causes illness or injury to themselves. So Munchausen syndrome by proxy was the old term for this, and as I say, we don't use it. But there's another term which is a person themselves pretends to be ill. It shouldn't be confused with those two things. Okay. So how do you think a fabricated or induced illness might present? Again, if you want to put your thoughts in the chat or put your hands up to share some of your knowledge and expertise. Yeah, failure to thrive, not putting on weight, gastro issues. Absolutely, we get quite a lot of cases where there's gastro issues, gastrointestinal issues. Low attendance at school. Yeah, absolutely. Anxiety and depression from the child. Home educated could be. Yes, absolutely. Lack of involvement in PE, for example, failed appointments, unexplained illnesses, injuries, child. Oh, absolutely, we're getting lots withdrawn. Child not having a diet is typically for age, isolated from support networks. Yep, using age adaptations when not needed. Fantastic. Yep. Multiple medical appointments. Wheelchairs not prescribed. Clingy to parents. Minor illnesses presented. Frequent. Yeah, absolutely. Yep, fantastic. Lots of experience of neurodiversity. Yes, absolutely.
Yeah, there was a comment from Helen earlier. Can this be a parent insisting a child is neurodivergent when they haven't got a formal diagnosis? And that is a really difficult one, isn't it? Because we all know that there are big waits for children and young people to get assessed. So it's certainly possible. I think that each case needs to be looked at on its own merits for what a parent is reporting and what you're observing within the realms of your professional knowledge of something.
Verbal reports of illness, injury over time, but no evidence of this in school. So when you see a very different picture of a child or young person when they're not in the care of their parent, and how they're presenting then. Yeah,
Jess says,
really
the educational
fantastic.
health plan isn't progressing. So if you've already been at the perplexing presentation stage and then you're just, nothing is getting better. Yeah, at that point, absolutely, Jess, when things aren't improving. Yeah,
absolutely. Fantastic, everybody. That's great.
Yeah, request this for extra funding. Yeah, request for disability living allowance funding and stuff like that.
Yeah, but remember there is genuine versions of all of these things as well. So, you know, it's never an exact science, and it can be very difficult to pin down. So we do need to be clear. Of course, And of course, oh, I've missed that bit. Something about focusing on something. It's gone. But
yeah,
anyway,
so needs-based
yes.
rather than not diagnosis, of
Yes.
course, the Children and Families Act. And also, gosh, yes.
Oh,
well,
wow, that's good.
This is criminality now, isn't it? When people are fabricating medical letters, there's really good evidence. If you think this is AI and not real, then yeah,
yes,
be very concerned.
That's huge. Absolutely. Requesting additional bedrooms, physical abuse of the child. Yeah, okay. So reported signs and symptoms found on examination are not explained by a medical condition for which the child is suffering. Medical investigations do not explain the reported signs and symptoms. There is poor response also to prescribe medication or the treatment. I've managed cases or been involved in cases where actually children have been taking anti-epileptic medication or reported to and then carrying on having seizures, but actually when that level of medication's been tested, they've actually not had any, there's none in their system. So although the parents are saying that actually they're giving their child that, they're not, or having poor responses. New symptoms are reported on the resolution of previous ones, and that is quite a significant feature of FII. Apologies for the random different font on here. I only noticed that when I looked at this today. I don't know why that's the case. The child's normal activities are being curtailed beyond what is reasonably expected. So my child can't do PE. I think somebody put that. The child, hasn't been coming to school. Lots and lots of different things. Parents reported signs and symptoms not being seen in the absence of the parent or carer. Over the time, there's repeated presentation in different healthcare settings with a range of signs and symptoms. And the seriousness of the stories and the actions of the parents don't marry up. So the parents reporting quite a significant collapse of a child, but they didn't take them to A&E, or they didn't call for medical assistance, or status seizures, and they haven't called for medical assistance. So that the seriousness of a story that the parents reporting and what the parents have done doesn't seem a logical thing that would happen.
There's just a comment there from Bridget, and this is increasingly common with the world today and social media. So being involved in cases where you become aware that parents or carers have got GoFundMe pages and things, and have said that children have got genuine conditions, health conditions, or that they need a wheelchair or they need some treatment abroad or something, where actually that's not the case. And we always think, how can people do that? But you'll all know from national media, local media, that does happen and is increasingly common.
Yeah, and the use of real significant medical terminology and talking through what you'd see on Google and what would happen there. So lots and lots of different indicators. That this is not a conclusive list. Lots and lots of different indicators. So again, just a bit of a scenario of fabricated illness. So the mother has asked school to inform the child's class teacher that her daughter has cancer. These are based on true historical cases for some time ago. Based on. Mother has shared a picture of the child's, her daughter's hair in her hand and states it's falling out because of her child's chemotherapy. Mother reports that a specialist team for an out-of-area child's oncology unit has visited the family at home, and they have attended 2 local hospitals, 1 private, 1 NHS for chemotherapy. Again, this feeding against different health practitioners, private health practitioners, and working against each other in that way. The child is known to a community paediatrician for mild developmental delay. And the mother informs the occupational therapist of her daughter's cancer diagnosis, who discusses this with the lead consultant. So that community paediatrician, where the child is known to for developmental delay. Okay, so it's raised concerns from that oncologist, and she's thinking, oh, I'm not quite sure here. That's an occupational therapist. So somebody's at my door, and I'm just going to ignore it for now. Cancer diagnosis is confirmed as untrue through the consultation review of the child's medical records. So that consultant has rightly looked into the record and thought, actually, I can't see anything at all. So that lead consultant then coordinates a professional meeting to gather information and discuss the concerns. Following that meeting, a referral to children's social care is made because of the concerns of fabricated illness, and a strategy meeting is held. At the strategy meeting, Health Service have raised concerns that they're unable to find any information to confirm the child's alleged cancer diagnosis. And that concern of that was because and parents is saying, you know, the hair's falling out, the child can't do certain things in school, and informing school of this diagnosis. So education rep at that strategy meeting informs the meeting that school has that mum has informed school of that, and she's undergoing treatment. The child's undergoing treatment. The hospital said the child has attended a routine outpatient appointment and no diagnosis has been considered. The GP has no recent contact with the child and no information to support the diagnosis. And Children's Social Care has no previous involvement with the family, has visited the mother, had discussed the cancer diagnosis with the social worker and provided details of appointments, had attended an ongoing treatment plan.
I can just see in the chat there, Jackie, I don't know whether to talk about that now. So Bev has said that there's a child that she's working with who has been visiting with her mum for a while, or he or she, not sure. And the child's got complex needs and she's only left the child once. Oh, and the child was fine, the little boy was fine. But when mum said then time to go home, he was biting. Oh no, mum said at home he was biting and self-harming, and now she won't leave him. And she won't let any members of staff near him without her intervening. And he's 3. Any advice? Gosh, well, I mean, if you're engaging with her, I think the important thing there is to try to work with her and stay alongside her and be understanding of what she's reporting, because probably the last thing you want to do is stop her coming by you know, saying the wrong thing. It's so difficult, isn't it? I think continue to observe what their behaviours are like and find out who else is supporting mum, and has she seen the GP? Has she asked for the child?
Does she have health visitor support?
Yeah, so you say the child's got complex needs, so I'm assuming that there's some health professionals involved, either a health visitor, probably a GP, possibly referred to paediatrics. But I suppose it's what are the child's complex needs, and finding out have they actually got support, and if not, do they need referral for support via the GP?
Yeah, I think it's understanding that picture while supporting the family with that. I think at this point, Bev, does that
being
sound...
kind and sympathetic? I think that's the thing at that stage, so that you can work on getting them more support and finding out more about the bigger picture.
Okay. So open house discussions with the parents will continue with their version events, progress through the child protection processes due to level of concern and emotional impacts this is having on the child. And professionals will continue to work closely with the child family under the statutory framework to understand the mother's beliefs, support the family and reduce the impact on the harm to the child. Any questions there at all? Oops, I'll go backwards. Does that make sense? So you can see the difference between the perplexing presentations of this supportive, and then to the point where we've got a concern that needs to go further multi-agency support. Yes, Katie.
Yeah, so I think my question was, how do we react when the reported incident, the severity of it and their reaction, because that's what's happened in something that I've been dealing with. So somebody has reported a lot of really quite worrying incidents happening, and I wasn't leading the meeting, so thankfully I didn't have to lead on that. But how do you kind of constructively challenge that? If somebody should have called an ambulance, if somebody should have contacted their GP, without seeming sort of overly critical or causing problems with the family?
I think it's having that open, supportive discussion of trying to understand what their responses look like and why they look like that, and what were the decision making. So it's a supportive discussion with them, certainly not in a meeting where there's lots of other people there, but whoever their closest worker is, trying to talk to them, because actually if that has actually happened and the parents haven't responded in that way, you could say it's medical neglect if the child needed to see and actually if that continues to happen, it certainly is, if we've given advice and support about what should happen if a child is unconscious for 5 minutes. Not that a child would be unconscious for 5, I'm just using an extreme example, Katie, but it's about supporting and really working with that family to understand why, what is the reasons, and then moving on from that within that supportive network. But if you have that continuously, it is a concern, isn't it? Yeah. Okay. Does that help, Katie? Yeah.
Yeah. Sorry, Jackie.
Yes.
Jess has very kindly commented on the earlier case where this 3-year-old is, yeah,
fantastic.
So
Good,
completely.
Yes.
Once we know there's already a lot of professionals involved,
Good, yeah.
it's trying to get them together, get all the information together, and it's a perplexing presentation, isn't it? Once you know that lots of support is being given.
That's helpful, because across York or North Yorkshire, it doesn't matter where you're working. The early help assessment should be used as a tool to collate all of those worries and concerns, collaborate it with the family, sit down and write it together, host a meeting inviting all the professionals in the family to figure out what's the family's biggest concern, because I bet you 9 times out of 10 it's not FII, it's families trying to navigate an incredibly confusing medical footprint and landscape, and getting lots of different messages, lots of different appointments. So I need to sit down and understand it from their experience. And you do that through the early help assessment and devise a plan with the family, either using the the education healthcare plan or
rehabilitation
around the family. Yeah, not the EHCP.
Yeah.
A plan.
Yes, the other one, education.
Yeah, a plan that is that you work with the parents and all the professionals around to figure out how you make this child and the life a little bit easier for them.
It's about working together most of the time. It's about working together to really understand, with the child at the centre of this, and understanding what the difficulties are from the perspective of the parent and family, and helping to support them navigate that way through. When we understand that, we can support and help. We do, of course, get situations where it's past that, but when we're in the early help space and that perplexing presentations, we need to understand that. Claire? Sorry, Jess, do you want to say anything else before I move on to Claire?
No, I think the key's in the
collation
of information.
Perfect, thank you. Claire?
I was just going to follow up from what Jess was saying, really, because I think my experience has sometimes been, in these perplexing presentations, that it can feel like it's moving towards fabricated illness, so it has to be led by health, and we can lose that team around the child, especially if there's it's possible that there are other safeguarding concerns coexisting alongside the perplexing presentation or the fabricated illness, and that sometimes that health approach can feel like it can be quite slow, but in fact there might be emerging concerns, and that needs that multidisciplinary approach, and needs often in the early help space, but needs that around the child as well. So not to get, I suppose, too distracted, my reflection, not to get too distracted, I suppose, by the perplexing presentation, and consider the whole picture of the other safeguarding concerns that might coexist as well. It was more of a comment than a question.
Yeah, no, I think so, Claire. And sometimes, and often we're waiting for test results, we're waiting for further investigations, which is all fine, and that takes time, and it does. That's just the case of our work, and that's how it is. But in the interim, doesn't mean everything's put on hold.
No, yeah.
What we're going to do to help and support during that time when we're waiting for that. How is this feeling for the child now, and what can we do now to help them and support them?
Yeah.
I was just thinking, Claire, so lots of people on the call won't know. So you're one of our named GPs, aren't
Oh,
you?
yeah,
So you will
yeah.
be involved in a lot of conversations about cases like this. And it might be worth mentioning, we haven't focused much about it on our presentation, but if there is any potential for psychological support, particularly for the parents and carers at an early stage. So if you're aware or think that parents have anxiety, depression, anything that you can signpost them to the early talking therapy support that there exists in your area, that is a good thing to do, because we know that there's not a defined service that can suddenly offer psychological support to families when they've become fabricated induced illness, and we think there are major concerns. So it feels as though generally if there is anything that parents and carers are talking to you about their own mental health, trying to encourage them to either talk to their GP or to self-refer to the local talking therapy services. That is a really good thing to do.
Yeah, agree. I'm just conscious of time, everybody, so I'm just going to come to Beth and then we'll move on a little bit, but really great conversations.
It's a very quick one because I don't know what the thing that's not an EHCP but sounds like one is. Health and Education Rehabilitation Plan.
Yes.
So that to me sounds like an early help assessment. Is the advice that we're doing both, or are we just doing one of those things that's basically doing the same thing?
I would do both. I would do both if I were you, partly because one is specifically around perplexing presentation, but as Claire has suggested, around the holistic needs of the child might be more covered within a team around the family approach. But essentially, if you're having, the meetings are the same because you're having the professionals in, you've got the family in, you're talking about the best plan. Although they're separate things, they can be held in the same meeting. The early help assessment, I don't think you do an assessment as a tool in the perplexing presentation.
No, you don't.
Yeah, so use the early help assessment to help you gather that information to kick off the team around the family for something to record it on. You can do both, but they're separate pathways, which is unhelpful. But
that's what I'm clarifying. I suppose the advice would be to run those two separate processes simultaneously.
Yeah, within the same meeting though, because you've got the same people across.
You've got the same professionals, and the same professionals would lead them.
And you're keeping the same thing.
Yeah, they cover both. Yeah, and the early help, that's a really good point, John. Johnny, the early help assessment will cover siblings and impact on them too, which is important.
I suppose it might be, sorry, I'll shut up after this. It might be helpful for us to see a copy of the Health, Education and Rehab Plan, because I'm wondering, my question is now, what's in there that isn't in the early help assessment that we could have, if that makes sense. So it might be helpful to see the two documents and then be able to compare them rather than us having to do two. I can put the link
in the chat because there is an agenda about how you run that meeting, Beth, within the partnership guidance and the procedure.
There is.
Thank you.
Okay, so I'm just going to finally go to an induced illness scenario before we move on to a summary in the last 10 minutes. So it's a scenario just to show you the final induced illness part of this. So child has very complex needs and a long history of involvement with health services, well known to the hospital trust, well known to the paediatricians and the healthcare professionals involved. So under the care of multiple healthcare professionals, including and out of area sleep disorder teams. There's ongoing investigations about excessive drowsiness. This child is asleep, essentially, really, really drowsy and unable to complete their normal lifestyle cares of living. And when a blood test is taken, there's amitriptyline evident in the toxicology test. So there's concerns about induced illness. When investigations are looked into, when this is looked into further, various diagnoses were found not to be true that the parent has reported. The mother and child were very well known to the ward staff, as you would imagine, with a child with very complex needs. So that became a real difficulty for the staff who were been working with this family and supporting this family for a very long time. So it had a significant impact on those health professionals and questioning their own practice. So in this case, it went through that process of a referral to children's social care happening, a strategy meeting, and being convened, and police investigation. And finally, the child was sadly removed from its mother, and the mum was imprisoned for 4 years because of this induction of illness to the child. So that's an extreme example of an induced illness. But we sadly do see cases where parents have given children medication and then reporting symptoms from that medication. So it's rare, but it can happen. But that is an extreme form of child abuse. And okay. So in summary, Sarah, do you want to do these last bits?
So this is a summary that's within our guidance in York and North Yorkshire. So if we're at the stage of you think there are alerting signs to possible fabricated or induced illness, it's easy. Is there clear deception? But let's go through a list of things which are clear deception. So that would include if you thought there were falsified documents, including where you said a person was using AI to generate medical letters which were not real. So anything, if you thought it wasn't a proper document, that would be a clear sign of this. We just discussed a case. So if there's anything where there's contamination of specimens, and if health professionals find that there, is anything that's really suspicious. So things like adding blood or sugar to urine specimens, things like that. Reports of blood in the nappy when it's not real. Interfering with medical equipment. So if things have been prescribed in hospitals, such as cannulas and lines in children, if there's a problem with multiple times where the lines have become blocked or detached, that's the word. Or anything where we've had children where there've been reduced levels, tweaking with oxygen levels for children in hospital. Anything where you think there's been withholding of either food or medication, and weight loss with no apparent cause, and lots of medical investigations which have shown that there isn't an underlying medical condition. Something like recurrent seizures because medication hasn't been given, or reported seizures when they haven't really been happening, you suspect. So my little crib sheet here says that it doesn't include factual discrepancies in statements that parents make to professionals. That's classed as an altering sign rather than clear deception, because it's the clear deception ones which necessitate an urgent referral to children's social care. So then induction of illness includes inappropriate administration of medicine, either prescribed or unprescribed, and then more extreme things like, again, there are very famous cases of, suffocation and reporting of symptoms in children and poisoning, but they're the most, the clear extreme examples. So then if is it induced illness, all of these things, is there an immediate risk to life? So then we're thinking, well, that's probable FII, and that is the point where we would like referrals to children's social care, or obviously the police if there's criminality involved. But that would, in reality, it's referral into either the MAST or the MASH, depending where you work. And then following referral, discussions take place with the multi-agency team about who's going to inform the parents of the referral and if and when it's safe to do so. Thanks, Jackie. Next slide. Yeah, somebody's put in the chat there just while I'm waiting for the next slide. What would be the reason to add sugar to urine? Yes, to fabricate diabetes. Absolutely. Yeah.
And I was just going to add to that. I was going to reply in the chat. It's not our role to understand why parents are doing things sometimes. Sometimes there's no reason for some of these things. The concern would be because it's happening. It's very difficult to understand why some of these things happen. Some of this does not make sense to us at all. and would be very clever if we did understand why a parent would want to fabricate or induce an illness in a child, but sometimes it just happens and we can't understand why that might be.
And obviously always in the background, the health professionals involved will be considering, does the parent or carer have a mental illness?
Yeah, absolutely.
Psychosis, something like that, but that's part of health to consider really then. So if there's no immediate risk identified, the cases should be managed as this perplexing presentation. If you work in a school, it's important to try to have an open and honest conversation with parents whilst supporting them, but saying this seems really difficult for you to manage. So let's see what we can do to support you more. And then schools should contact health professional involved if they know a named person, or to the GP, who will then probably make a paediatric referral. And then the lead health professional, it's their job to ascertain the child's current state of health and daily functioning. And it's a really huge task, but they are responsible for then collating all the current health involvement, reviewing and verifying all the reported diagnoses, speaking with the child if they're old enough to establish their views, fears, beliefs, wishes, and also the parents to try to find out what's going on from their point of view, but also with consent with the wider family. Obviously, if it's fabricated illness, it might be in the interest of safeguarding to consider the wider family and what's going on for them. But at this point, you're asking for consent to just think about other family members and how the family are functioning. Next slide, please. Thank you.
This is our final slide, Sarah. We've only got 2 minutes.
Yeah, so it's self-explanatory. So if when health have obtained a consensus for all the professionals at that professionals meeting, including education and children's social care if they're involved, if their physical or psychopathology assessment does not fully explain the concerns, either the parents are going to support a health and education rehabilitation plan, in which case that gets set up and then reviewed every 3 months, or if they don't support it, that's the point of children's social care referral. If when you've gathered all the information, things have got better, or you've established that the child's physical illness or psychopathology is explained, obviously there's no further need to go down this pathway, and then you'd obviously put support in place to help manage whatever the situation is.